everyone, and thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Kathy Riley, the Associate Director of Programs at CSELA, and really honored to welcome you to this week's webinar titled, Can a Low-Carb Ketogenic Diet Actually Be Good for Cancer? So before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization that provides vital social and emotional support to families facing cancer. And that includes patients and caregivers and their loved ones, all at no cost. Our programs include support groups and healthy lifestyle classes, social activities, and educational programs like this one. So if you would like to learn more about our services or watch past webinars, you can visit our website at cancersupportla.org, and we'll be putting that in the chat as well. Before I introduce our speaker for today, please note that your video and microphone are automatically disabled for this webinar. Enter your questions for the speaker into that Q&A feature that's found at the bottom of your Zoom window. Questions will be answered at the end of the presentation. We may not be able to get to all of your questions today, but our presenter is going to share his slide deck at the end of the webinar for anybody who would like a copy of that. The chat feature is also open to share comments and resources with other participants or ask those of us at CSCLA any questions you have. So limit the chat comments to information that's relevant to this topic. All right, I will introduce our speaker. Dr. Stephen Freedland is a professor of urology, the Warschaw Robertson Law Families Chair in Prostate Cancer, and the Associate Director of Cedars-Sinai Cancer at Cedars-Sinai and a staff physician at the Durham VA Medical Center. He focuses on prostate cancer with interests in lifestyle, health disparities, and risk stratification. He has published over 800 studies, including papers in the New England Journal of Medicine, JAMA, Journal of Clinical Oncology, and other journals. He was co-PI of the global Phase 3 EMBARK study. He sits on the editorial board for multiple journals, including Nature Reviews Urology, and is editor-emeritus for prostate cancer and prostate diseases. He earned his MD from UC Davis, completed urology residency at UCLA, and a urological oncology fellowship at Johns Hopkins. His research interests include the role of diet, lifestyle, and obesity in prostate cancer health disparities, and prostate cancer risk stratification. It gives me great pleasure to introduce Dr. Stephen Freedland.
It's great to be here. Really appreciate the opportunity to talk about some thoughts that we're having in terms of diet and nutrition and lifestyle, some of our own research. But we've had this age-old adage for many years that fat is bad. We need to avoid fat, and that's been the focus of nutritional guidance for a long time in the United States. And what we're starting to realize is, fat may not necessarily be the enemy, so to speak, but maybe it's carbohydrates and particularly simple sugars. And so taken to the extreme, if carbohydrates are bad, then we should avoid them entirely. And that's really the question is, what does that do for cancer? And if you're not eating carbohydrates, you're going to be eating more fat and protein. So there are some concerns, theoretical concerns. So that's why we've gone through it kind of methodically to make sure we're safe, and we're actually seeing some interesting results that I'm excited to talk to you about today. Next slide. So I'm going to talk a little bit about just the importance of clinical trials. And I think if I can leave you with any message, it's if given the opportunity, please participate in clinical trials. We actually see patients on clinical trials, even on the control arms, do better than patients getting the exact same treatment, not on a clinical trial. Just because a clinical trial is not just good care, it's optimal care. So we really follow the patients closely. And ultimately, this is going to define how we treat cancer patients tomorrow, how we treat it today is based on clinical trials conducted yesterday. So we're always trying to improve things. So just really please enroll in a clinical trial if there's one available. And we're going to talk about prostate cancer mostly with a little bit of a nod, so to speak, to brain tumor and then conclude. Next slide. So, I guess you could argue in some ways, do we really need clinical trials? We didn't have a clinical trial showing that smoking causes lung cancer. It was based on observational data. We've never done a randomized trial of whether parachutes improve outcomes in people jumping out of airplanes. And yet, if you could jump out of an airplane, I certainly would do it without a parachute. So why do we need clinical trials of diet? I mean, don't we all know how to eat well? Well, let's look at some of the data. So next slide. There's certainly, again, focus on this low fat. There's many epidemiological studies that indeed suggest low fat lowers cancer risk. But the challenge is in the real world, people who eat low fat diets also often have other health behaviors that may pretend lower cancer risk. So they tend to exercise more, eat more fruits and vegetables, they eat less refined sugars. So the question is it really the fat in the diet or is it something else? And so again, you don't know until you do a trial. So the Women's Health Initiative randomized almost 50,000 postmenopausal women to a low fat diet with eating more vegetables or no change. That was the study. And as you can imagine, we saw tons of benefits, right? Well, let's take a look. Next slide. We actually saw no difference in breast cancer risk, no difference in colorectal cancer risk, no difference in overall cancer risk, no difference in heart disease, stroke, diabetes. You go down the list, no effect. And the people who still believe in a low-fat diet say, well, the patients weren't adherent long enough. Or, we didn't run the study long enough. But really, if you do a 50,000 person randomized trial and see nothing, maybe it's the hypothesis that's actually wrong. And so that's why we need to do clinical trials, because what we think we know is not always correct. And that's the important thing. Next slide. So again, we really need to understand what is right. We need to understand the mechanisms. And in my world, that often starts with animal studies. We've done a lot of animal studies with low carb diets in prostate cancer before I treated a single patient. And the patients I initially treated were on clinical trials. So we would learn. I started with mice. We understand the mechanisms. We started with small, intermediate, endpoint driven trials. So we didn't jump to a 50,000 person trial. We did 50 people trials, really trying to understand the mechanisms. And then, again, maybe compliance wasn't good enough, which in and of itself tells us something that basically says if you eat a little low-fat diet, you're not going to get those benefits. Maybe you need to be really hardcore low fat. It's possible. It's a hypothesis. It's worth testing. But, I give up a little bit of fat here and there. That's not going to do it. So we need to understand how we can actually deliver, even if we come up with the optimal lifestyle. How do we actually get people to follow it? Um, and ultimately, you can't study every single diet, right? We need to pick and choose based upon what people are interested in and where the science takes us. Next slide. So, what are some of the potential benefits and or mechanisms, I would say, by which a low carb ketogenic diet may have benefits? Well, in general, people lose weight. And weight loss is thought to be good for cancer. You're lowering growth stimuli, you're lowering calories, lowering nutrients going to the cancer. We certainly lower sugar levels. And again, I think the world has evolved from the 70s and 80s and dating myself here when I was growing up, where it was all about fat. No one even talked about sugar. To now we understand that sugar has negative effects as well. Certainly lowers insulin levels. Insulin is a growth factor for many cancers. Reduces inflammation. We hear a lot about inflammation. We try to eat an anti-inflammatory diet. Well, Carbs promote inflammation. So eating low carbs is anti-inflammatory. Um, we alter the epigenetic signaling. And what that means is we all have, by and large, the same DNA, though we obviously vary slightly among each other. But it's which genes are turned on and which genes are turned off can make all the difference. And that's what a low carb diet kind of changes some of those signalings we think in a favorable way. It alters the microbiome. Um, which is one of the hot topics in science in the lay public as well. Again, we think in a positive way, but one nice thing about a low carb diet is, or at least keto, is it's quantifiable. You can actually do blood ketone levels, and we can record them. And so we actually can measure compliance, which is amazing to think in a dietary study. Because typically in a drug study, if I give you 30 pills for 30 days and you come back at the end with 10 pills left, I know you only took 20 of the 30 pills. Now, yes, people can, lie about that and flush things down the toilet, but a lot of them actually, trials now actually are kind of foolproof for some of that. But in diet, it's very difficult. Unless I'm giving you the food to eat, and I still don't know that you're not snug, getting Snickers bars on the side. With this, we can actually measure in the blood compliance, which actually makes it very attractive from a scientific point of view to be able to actually study this. Next slide. So what do we know about this in prostate cancer? Next. So this was, a study that we'd done. And again, we'd done a couple mouse studies that showed we could delay progression of prostate cancer. We actually gave mice a ketogenic diet. First off, they ate it. They ate a lot of it. If you let them eat unlimited, they would actually gain weight. So not exactly what you see in humans. So again, mice are not small humans. I understand that, but it gives us a place to start. And we had seen in several mouse studies that really low carb ketogenic diets did seem to slow tumor growth. So that's what we went and said, well, let's see what we see in people. So this was carbohydrate and prostate study 2. We did a CAPS 1, which is in people starting hormonal therapy, and seemed to have some benefits, seemed to be safe. So here we actually said, can we slow prostate cancer growth? And for people who know prostate cancer, it's a very slow growing disease, just in general, usually. And so there's only a certain scenarios, windows, we can actually see anti-cancer activity in a small, um, kind of 6 month type window. Um, and one is in patients who have a recurrent prostate cancer. And so they've had surgery, had radiation, the PSA is rising, and we now want to see, we can measure how quickly the PSA rises. We know if it rises really quickly, that's bad. So if we can slow the rate of rise intuitively, that's a good thing. So that's what we sought to do. We randomized people in this rising PSA after treatment to an extreme low carb diet, 20 grams of carbs per day. Um, versus control. Control was eat what you want. Don't make any changes. So to put this in context, anything you could think of as a carb, cookies, cakes, sodas, candies, all of that was out. Toast was out. Bread, pasta was out. Fruit was out. Fruit had too many carbohydrates. Alcohol definitely was out because that actually converts into carbohydrates in the body. And so basically, it was meats and vegetables, cheeses, eggs, other things of that sort. And the primary outcome was that what we call the PSA doubling time, DT there, PSA DT. That's essentially the rate at which PSA goes up. We looked at a number of other different things, weight loss, resting metabolic rate. And, we were planning on doing 60 patients. We got some new imaging for prostate that came out towards the end of the study, and all of these patients were finding some lesions in them that we were starting to radiate. And so no one wanted to sit around and just watch their PSA go up in this space. So the last year or two, we enrolled, I think, one patient. So ended up doing an interim analysis after 45 patients completed it. And that's what I'm going to show you the results from today. Next slide. So we ultimately enrolled 78, randomized 57. Um, and this, normally is pretty uninteresting when you see these in slides and in figures, but I actually find this pretty informative. And of the 30 patients that got the low carb diet, 26, almost 90% completed the 6-month study. And you might say, wow, that sounds like a really tough diet. I can't believe they're not dropping out and everything. I can't think that they're needing other treatments. They did 90%, almost 90% completed the study. Whereas in the standard diet, we actually had more people drop out because they needed treatments. Their cancer was growing faster. They needed treatments. So we had about 30% of patients almost drop out. So about 70% completed in the standard diet, almost 90% in the low carb. So there's just your first sign that maybe we're doing something right for the patients. Let's look at the data more carefully. Next slide. So this is what did they take in? And this is by self-report. So again, are they lying to us? Are they filling this out to tell us what we wanted to hear? Perhaps. I think unlikely, because it's really just the flip of a coin, whether they got the control or low carb. But they really, really cut the low carb. We told them 20. They hit about 30 or so. I think it was mid 30s. So they didn't quite listen to us all the way, but still, it's a pretty dramatic drop in terms of how much carbs they took in. Next slide. So what do they eat instead? Well, they eat a little bit more protein, but not significantly more. So it's not like they said, well, if I can't have my baked potato, then I'm going to just have twice as big of steak. Not really. We didn't see a lot more protein intake. Next slide. And we didn't see a lot more fat intake. A little bit, it's a little bit, but not dramatic to account for that really carb reduction. So if you think about your traditional American dinner plate of kind of the meat, a starch, and a vegetable, you think about now it's just a meat and a vegetable. The starch is gone. It's not like there's more meat, more vegetables. It's just the starch is gone. Next slide. So the key question is, did it work? And the answer is, well, kind of, sort of, yes and no. Depends on how you look at it. So let's look at these data. So if we just say, did it work at face value? That's the top line. The doubling in the control arm was every 15 months, and the low carb LCD, low carb diet, was 22 months. So it was a little bit longer. Did not reach statistical significance, but it was a little bit longer. And then the next question is, well, we were tracking their PSAs. They were going up before the study. Did they slow down? And you would expect by random chance, half the time it's a little bit slower, half the time it's a little bit longer, just kind of noise. And that's what we saw in the control arm. About half the time, 42%, it went down, the doubling time. Whereas in the low carb group, almost 3/4 of patients experienced slower rates of PSA rise on the study than they did the before. But it's a 45-person study. It's pretty small. And whenever you have a small study, it's subject to variations that you have slightly more bad disease in one group, slightly more one ethnicity. Can have some imbalances. So when we adjusted for those factors, what we saw is actually the control group, their PSA was doubling every 12 months, and the low carb was 26 months, over twice as long, which was statistically significant. And then as you lose weight, you actually lose blood volume, and PSA will actually go up faster than you think because you're hemo concentrating the PSA. Alternatively, if you gain weight, you're going to hemodilute your PSA. So if we actually adjust for that, we saw in the control arm 13 months, again, about a year, whereas in low carb, it was doubling every 30 months, 2.5 years. So if you could say, look, my tumor's doubling in a year versus my tumor is doubling in 2.5 years by just changing your diet, pretty impressive. Again, small study, hypothesis generating, certainly supports that there might be some value for this, but and we're in the process of trying to design bigger, larger studies to kind of confirm this, but pretty exciting. Next slide. So, how about other factors, kind of metabolic factors? So, if we look at weight, to me, that's the most profound difference. And again, flip of a coin, heads versus tails. It wasn't people came to us and said, I really want this diet. No, they said, yeah, I'm open to a diet study, but if it comes up heads, I'll just make no changes. It's fine. If it's tails, I'm willing to go on this extreme diet. And if they got heads, control, they lost zero point 0.6 kilos, about a pound over 6 months. Not really much of a change. Whereas on the low carb arm, they actually lost about 25 pounds of weight. This is before Wegovy, before Zepbound, no other GLP-1s, other medications for weight loss. This is just diet. The flip of a coin decided whether your weight stayed the same or you lost 25 pounds. It's really that profound. So, did they lie to us in telling us what they ate? Perhaps, but clearly they did do something different to lose 25 pounds. Cholesterol didn't change. HDL, which is the good cholesterol, actually didn't change in the control arm, went up 8 points in the low carb, which is statistically and arguably clinically significant. LDL went up a little bit in the low carb arm, didn't change in the control. So the ratio, because there's a lot more LDL, the ratio actually gets more favorable for heart disease. Triglycerides, which is often a measure of sugar, went down statistically significantly in the low carb versus control. Glucose didn't change at all. And HbA1c, though, which is a measure of your glucose levels of the last 3 months. So anyone who's diabetic understands HbA1c tracking. A drop of 0.4 is actually pretty profound in an HbA1c. That's on par with what we see with medications like metformin or other things. Again, just by changing diet for 6 months. Next slide. So, how about that cardiovascular risk? We mentioned it looks favorable, but we actually did it. We used the Framingham Heart Study, which is the classic study that showed the risk factors, cholesterol, smoking for heart disease, and we plugged in the numbers of our patients. And there's a couple ways to do the curves. You can either use it using lipids or body mass index, which is your weight divided by your height squared. And what you end up with is in the low carb arms in the blue there is your cardiovascular risk is going down. So despite eating perhaps a little bit more fat, a little bit more protein, but really giving up those carbs, cardiovascular risk, estimated cardiovascular risk went down. Whereas the control arm, as expected, because we told them to make no change, cardiovascular risk didn't really change. So really significant, clinically important reductions in estimated cardiovascular risk. Next slide. And then metabolic syndrome. We've been hearing a lot about that recently. And so that's basically a risk factor for developing diabetes, heart disease, many other factors. And if you look in the top in the control, again, no difference, which is to be expected. We didn't tell them to make any dietary lifestyle changes. But the low carb all of a sudden it went from about 30% of patients having metabolic syndrome to about 10%. So in almost 2/3 of those patients, metabolic syndrome was reversed and went away simply by giving up carbohydrates for 6 months. Really, really dramatic effects based upon the flip of a coin. Next slide. So that's the data we have for prostate cancer. We're trying to get some more studies going. I'll tell you about another study that we have going in prostate that we don't have the results. But the question is low carb. And to be clear, we used low carb diets, not ketogenic. Ketogenic is similar in that you really have to give up carbs, but you also have to take in a lot of fat. And we try to get good fats, avocados, oils, other things, not so much saturated fats that we think are bad that we don't actually know. Trans fats definitely are. We try to avoid those. But the question is, can this extreme diet actually help other tumors such as brain tumor, glioblastoma, one of the most lethal cancers out there, just horrible. And it's in your brain. It's just, it's something that we wouldn't wish upon anyone. We're trying to make a difference here. So can these diets help? Next slide. So we actually have a phase 2 clinical trial of a ketogenic diet versus control for patients newly diagnosed with glioblastoma. Not all brain tumors, but the most lethal kind. And Dr. Jethro Hu is my partner, or I should say I'm his partner. He's the one leading this, and I'm helping. And our primary outcome is overall survival. Can we actually make patients live longer? We are measuring a lot of quality of life, cognitive function, activity levels. So not just quantity, but also quality of life. But we have some mechanisms that we think and can really impact things and hopefully make patients live longer and better. Next slide. And so the trial is open. So if you know of patients newly diagnosed with GBM, glioblastoma, we'd love to talk to them about our clinical trial. And it's newly diagnosed. They consent. They get randomized to standard of care, which would be radiation and temozolomide as a chemotherapy, um, and or that versus standard of care plus ketogenic diet. So everyone's getting good standard of care. Um, and then there's a 14-day transition period, and then they get 16 weeks of the diet. So we're talking about 4 months, a little bit shorter than what we did in the prostate study. And our assessment is that we think we can actually, if we can go back one, thank you. Nope. There we go. Yep. Thank you. So we actually think we can make patients live better. And we actually have seen some MRI changes. If you look in the bottom, the white area in kind of the front left side of the image of the MRI down there on the bottom. And after treatment, granted, they got surgery, chemo, and radiation, but all that white, bright stuff went away. And we don't typically see that without the ketogenic diet. So could it be the surgery? Could it be the radiation? Could it be the temozolomide? Absolutely. But it's just a case that we don't typically see in patients not on a ketogenic diet. So this is one of the reasons we have excitement and hope that we're going to make patients live longer. So again, if you know of patients, we'd love to talk to them about our clinical trial. Next slide. And so we're doing a similar trial in prostate cancer, not quite exactly ketogenic diet, but a fasting mimicking diet, which is in itself a different diet, very interesting. And basically, what this involves is severe diet restriction for 5 days per month. So you basically take supplements, soups, and different things that have somewhere between 2 and I think about 500 calories. Normal caloric intake for a person is about 2,000, give or take. So really, really restrictive diet, but 5 days a month. And the rest of the days, we encourage patients to obviously eat healthy. The control arm is not getting the fasting mimicking diet. And this has been shown to have benefits in breast cancer. And now we want to see in prostate cancer. So this is patients with metastatic, what we call hormone sensitive prostate cancer. So not that's resistant to hormonal therapy, but newly starting treatments for metastatic hormone sensitive prostate cancer. They have to be receiving standard of care treatments. And there's a lot of different treatments they can get. And then they're randomized to a fasting mimicking diet, 5 days per month for 6 months, or control, which is, again, keep eating what you're eating. And the goal is in prostate cancer, a lot of it revolves around PSA. And we're trying to see how low we can drive that PSA. Essentially, can we get the PSA even lower by adding the diet to standard treatment? Um, we're trying to get funding to do this with a ketogenic diet. We don't have that funding in place though, so it's probably going to be a couple years realistically until the ketogenic diet gets open. Just given funding, and that's if we're lucky and do eventually get the funding. These are not easy to fund, so we're always looking for not only patients for our trials, but if people are interested in helping support us philanthropically to get these trials going and support them would be very interested in talking to people. Next slide. So, in summary, we don't know the best diet for cancer. Anyone who tells you they know is lying to you. They may have opinions, they may have beliefs, they have thoughts, but they don't have knowledge. We don't know for sure. And I try to keep what we think versus what we actually know. Um, and so certainly at Cedars, we've done several trials now that have shown or suggested benefits to low carb for both prostate and brain. We did some preliminary brain work, which I didn't have the time to show you. But that's where we're now doing the bigger trials. So we're doing the ketogenic trial in brain tumor. Prostate, we're doing a fasting mimicking diet, which is open and enrolling. We just completed a study of walnuts. We now have a study going on of urolithins. This is for patients scheduled for prostate cancer surgery. And urolithins are the active metabolite of pomegranates. So it's randomized to urolithin or placebo. Again, we try to do ours very scientific. I think single arm diet studies are very tough because you get highly motivated people um, who, don't necessarily represent all people. And then you compare them to what we've done historically, and they always look better, but that's why we need to really do randomized trials in lifestyle and diet. And that's the way we've always done ours. So the walnuts was randomized, urolithin is randomized. We're doing well. We're about halfway, 40% enrolled, but we're still looking for more patients. Um, and again, I think Cedars is doing some phenomenal work in lifestyle. I'm sure other places are as well. I'm not here to say negative about anyone. I'm just here to highlight the great work our teams are doing at Cedars. And again, final plea, if anything, please, if given the opportunity, participate in trials. It will help you, it'll help your care, and it will help move the field forward. So on that, next slide. I want to thank a lot of different people who have helped in the prostate and the brain tumor, but most importantly, the patients, their families who've put their trust in us and allowed us to have the data that we have today and to continue to move the field forward. Obviously, we couldn't do this without sponsors. We have gotten some federal grant funding, but a lot of it has been private foundations that we're very grateful for and would love to talk to anyone who's interested in helping to support us philanthropically. Next slide. And I'll leave this up for a minute here. I love this cartoon, but there's my email. Feel free to reach out to me if I can help with anything. And I'm happy to take some questions.
Thank you so much, Dr. Freedland. I have heard a similar talk from you before, and I learn more each time I hear about this. So thank you for that really informative talk today.
Y- Yeah, no, absolutely. And I do apologize for anyone who was, I gave this very similar talk 2.5 years ago. So if anyone was here before, I apologize for reusing the slides, but the field moves slowly and we have a few new trials open, but you know, anyway.
So a few questions have come in. So one is how,
And we could probably do away with the slides now if you want.
okay,
There you
great.
are.
So how does one find information on clinical trials pertaining to prostate cancer?
Absolutely. Great question. So the best resource for identifying clinical trials is clinicaltrials.gov. Gov. So clinicaltrials.gov. And you can go in there and you can search for your condition, whether it's prostate cancer or breast cancer or whatever it is. And maybe, if you want to be more specific, you can put in if you're looking for a specific agent, immunotherapy, or you're looking for diet, put your stage in if you know that, and hit return and see what comes up. So it's where we go often when we're looking for clinical trials for our patients if we don't have something at our center.
And can an individual take advantage of a clinical trial if it's not in their at an institution in their particular city?
Absolutely. So many trials nowadays are going towards a more virtual model. um, where, and we're starting to do this with some of our trials. There's companies that do mobile phlebotomy that we can send a phlebotomist out to the patient's home to draw their blood. Often there is a visit or two that needs to be done in person, so sometimes it can be tough to do it 100% remotely. But we welcome patients, all over the country and things. So absolutely.
Great, great. And we're getting some questions in the Q&A. So if you're here and you have a question, please type it into that Q&A feature at the bottom of your Zoom window. One of the questions is, what can we substitute uh, for meat if we don't eat a lot of meat and we want to have a low carb or ketogenic diet?
So it's interesting. So we have specifically excluded vegetarians from our ketogenic diet because it is extremely difficult to get that amount of protein and fat without meat sources. I think there are a lot more substitutes and products available out there that can be done. Um, but I think it's challenging. And so it's interesting. I've heard this from a lot of patients of, well, I don't eat meat, but I'll eat fish. I'm like, well, fish is still a meat, So, that'd be one of the questions. Is it really vegetarian, vegan, or is it a pescatarian? Not to necessarily place labels because we all have our own dietary habits and depends on the day of the week, or if it's a birthday, we may break our rules. So that's the conversations I would have. But for someone who is really a vegan, vegetarian, very anti-meat, it is very difficult to get that amount of fat and protein you need. Again, a lot of oils, olive oils, avocados, other sources, but it can be challenging.
Okay, great. Someone is asking a question. I think it was referring back to one of your slides with the carbohydrate and prostate study. Was the starting BMI, what was the starting BMI average in each group? And then weight loss during cancer treatment is not always beneficial.
Yeah, so we need to there's two thoughts here. So one is the median BMI was about 29, if I remember correctly. And because we knew the low carb diet would cause weight loss, we required the patients to be overweight or obese to get on the study.
Oh, okay.
So we were focused on those who had weight to lose. The second thing is a very important point, and I agree, but that's why I think it needs a little bit more explanation. So there is, cancer is obviously there's many different kinds of cancer. There's many different treatments, and often we will do treatments for cancer, and then we will wait to see how well it works. And so there are periods in there where patients are not actively receiving treatments or don't have very late stage cancer, have early stage cancer, where we do think weight loss has benefits.
Hmm.
Yes, if patients have metastatic disease, very aggressive, very late stage, we often see weight loss as part of the terminal events in cancer. That is not a good thing. There's actually work going on to try and prevent that weight loss and keep people's energy and strengths up. That's not the kind of cancer we were studying. We were studying patients way earlier than that and saying, can we get patients to lose weight to prevent them from progressing and needing treatment later on? So I think the nutritional advice that you get really needs to be tailored to the specific situation. So, for example, we talk about antioxidants, right? We all want to take antioxidants. Antioxidants are good for us, they help prevent damage and things. But what's interesting is if we really break this down, so we're blocking oxidizing antioxidants. What is an oxidant? It's when oxygen gets damaged, becomes what we call a free radical, floats around and damages DNA, okay? Which can lead to cancer. And in general, that's a bad thing, right? So that's why we take our antioxidants. But interestingly, that's exactly the mechanism by which radiation therapy works for cancer. It oxidizes oxygen, creates free radicals, damages the DNA, and kills the tumor cells. So there's actually data if you're taking antioxidants during your radiation, you actually make the radiation less effective. So we really need to be careful and think not all nutritional advice is the same for every cancer at every stage, at every step of the way. And that's why we are very careful in selecting patients, populations, where we do think a ketogenic diet, weight loss, metabolic improvement can improve cancer outcomes. But it's not, there's no one diet. And that's why I say there is no one best anti-cancer diet. There's so many variables that go into that equation.
Yeah, great advice. And which leads into nicely into our next question. Are registered dietitians involved in these studies to help with diet education and diet assessment?
Absolutely. They are crucial. And that's why I think part of it is in the study I showed you, the low carb diet, we had such good adherence and people staying on the study is they met with the dietitian weekly for 3 months and then every other week for 3 months. So there's a lot of hand holding, a lot of involvement, a lot of social support in that sense. So I think that is crucial, but I think it's also crucial to understand as much as people and physicians have biases of I think this works, I think this doesn't, dietitians do the same. And it's interesting with us doing the ketogenic diets, I've been very fortunate to find dietitians who are either believers in that or certainly open to that idea, but not all dietitians are. And we recently, I was talking to my dietitian for our studies, and actually said she was talking to a dietitian recently at Cedars who wasn't a huge fan of ketogenic diets. And her comment to me was, I hope she's not covering for me when I'm on vacation, on these trials. Um, because, and that's why we're doing it as part of a clinical trial. So we can learn if it's good or bad, either way, we're going to learn something from it. But, if you were dead set on a ketogenic diet, not every dietitian is going to tell you that's fine, go for it, and here's how to do it. Some are going to tell you that's horrible, avoid it. Others will say it's fine, but I'm not sure how to advise you. So you got to just like, you don't go to you don't go to the brain surgeon when your toe hurts you necessarily, right? You got to find the right physician. You got to find the right dietitian who's going to work with you and be open to your ideas.
Great. And then on a different topic, are there any cardiac risks with the amount of fat that's required?
So, to the best of our knowledge, no. But it's obviously something we're tracking and something we're careful about. Again, in our low carb studies, we saw estimated cardiovascular risk go down. So, to the best of our ability that we see, the risks go down, not up. Um, and in the ketogenic diet, again, it's something we are tracking and keeping an eye on, but so far have not seen that be an issue. But studies are still ongoing.
Great. And then another attendee says, great talk. Do low carb keto diets help mainly by improving patients' metabolic health, things like insulin and glucose, or are they actually depriving the tumor of fuel since tumors use different fuels?
Great question. I think both. I think weight loss means you're taking in less calories than you need. And less calories than your body needs. Tumors need even more calories, more nutrients. So if your body losing weight, then we know the tumor is getting deprived as well. So we think insulin. Insulin is a direct growth factor. They're all kind of intertwined. Insulin is that signal that, hey, you got plenty of energy. Let's store some up for the winter. essentially. And if winter's not coming, there's no need to store up all that energy. We want our insulin to be low. So I think it's a combination of all of those factors. And it's very difficult in a diet study to really identify the mechanism because I think there's multiple. And the scientist in me wants to know the mechanism. The clinician in me says if it works, it works. It doesn't matter.
Yeah. Yeah. And then what if someone is a type 1 diabetic with slow growing prostate cancer? Would a low carb diet be supportive for that patient?
Absolutely. And I think that's actually one of the best candidates for a low carb diet because we know low carb diets can really improve insulin control. Um, and so you need to work with your diabetes doctor because the amount of medications you need for your diabetes may actually go down. And we've actually seen cases of people with diabetes that can actually stop all their medications because they're now on the right diet. I'm not saying that will happen to you or any individual person, but we have seen that. So, working with your doctors, making sure you're monitoring your blood sugar, it's not getting too low. But I do think cutting out the carbs can have a lot of benefits for diabetes. That's one of the big places keto and low carb diets have found a home in weight loss diabetes. And again, our data would suggest there may be benefits for prostate cancer. So, I would feel very comfortable, given the data we have now, recommending that.
And then you talked about a recent study, I think it was a recent one, the 5 day a month fasting diet.
Yeah.
Someone is asking, would intermittent fasting, 8 hours on, 16 hours off, be the same as the 5 day a month? Would it mimic that 5 day a month fasting diet?
It's a great question, and we don't know that answer, but the you know they're different because one is in 5 days consecutive month, you're really, really starving the tumor. Really, really starving the tumor. Um, a 16-hour fast is probably not a huge calorie deprivation, starving of the tumor. So one of the thoughts is with that kind of 16 off, 8 on, and some people are even more restrictive than that, is that it's just hard to eat your full allotment of calories in 8 hours, that you're not getting that 2,000 calories again as a ballpark average. Maybe you're getting 1,800 calories. So you're slowly depriving yourself, and people tend to lose weight with that. Not everybody. But so ultimately they are there work by, I think, some different mechanisms. Um, and the challenge is when you're doing a diet study, if we had done 5 days a month of fasting, a fasting mimicking versus what I typically will call time restricted eating, or TRE, because you're restricting the time over which you're eating, just to differentiate between an intermittent fasting, because that term is used for both. Um, let's say we do that study. I'm just saying for scientifically, and put on your hat, we do that study and we show no difference. Is it was both worked or neither one worked?
Hmm.
You don't know. So we tend to do our trials versus nothing. We do often offer the intervention to people after the study because otherwise, why would you sign up for the study and be a guinea pig if you want? But again, this is the way we're going to learn. And so, as much as I want to do a keto versus vegan, that's the diet that the trial that I think would excite me because I tend to be more on the keto camp, but I think vegan is a good diet. I think it's more my own personal taste buds. I tend to be more on the carnivore side of life than vegan side, but that's just personal. But I think it's probably going to be a negative study in that there's no difference. But
Mm.
again, is that because both worked or neither worked? I don't know.
Yeah. And then someone else is saying it seems like many of the harms of carbohydrates come from eating simple processed carbs like processed sugar and white flour. What about the proven benefits of high fiber diets and complex carbohydrates like whole grains, beans, and legumes?
Yeah, so it's a great question. So I mean the benefits that we have seen are in people eating normal kind of a Western type diet. And I often think of fiber as kind of a sponge. So it's going to absorb, if you will, or that's not the right word. It's going to surround some of the bad things that you eat and help flush them out through the colon. So, for example, if you eat a fruit with the juice and the fiber, you actually don't absorb as much of the sugar as if you just drink the juice.
Mm.
So it kind of slows the absorption of the sugar. But if you're not eating sugar, are there as much benefits to fiber? Little less clear. It can do similar with cholesterol. Um, could we have refocused things on net carbs, so that you could introduce salads, for example, a good
Mm.
source of fiber. You're not actually absorbing the carbs. Possible. I mean, there's a lot of possibilities. It's just, again, the challenge of trying to do even a 40-person study to answer all these questions is tough. But it's a very interesting question and thought.
Yeah, a lot of questions and a lot of different types of cancers and different types of diets. Well, I'm looking at our time. And I think we are good with our questions, and we're about at the top of the hour. So again, Dr. Friedland, thank you so much for
Thanks for
spending
having me.
this hour with us, particularly right before a holiday. So we're so happy to have you with us today, and thank you for this great information and for that really informative Q&A. And then I want to thank our attendees today for your engagement and participation and really, really thoughtful questions. And Abby, I think we have a closing slide. Is that correct that we're going to share? And this will just give you our website. So if you want to learn more about Cancer Support Community Los Angeles, and then if you have any questions for us, you can email us at info@cancersupportla.org. If you would like a copy of today's slides, email us there, and we will ensure that we get you those slides. And then we like to feature one of our resources when we close out these webinars. And if you are diagnosed with prostate cancer and you are looking for support, this is one of our prostate cancer support groups. You can join with others to gain valuable information from them and support. To get started, you can take a picture of that QR code, or you can go to our website and glean more information there. This group meets the first Monday of every month from 6 to 8 p.m. But please join us if you're looking for additional support. And with that, thank you, everyone. Have a great holiday weekend ahead. And thank you again, Dr. Friedland.
My pleasure. Thanks for having me.
All
Happy
right. Take
holidays.
care, everyone. Happy holidays.